The final part of the module on lumbosacral examination while the patient prone. There's a lot of information going on here, and you might be spending a little time. So make sure there's a pillow underneath the belly so the spine isn't arched up, and for comfort underneath the ankles so the ankles aren't pressed. I oftentimes like to have my patient comfortable with the head in the hole, but just make sure that they're not under a lot of tension. It'll give you some false positive readings. So what we want to do first, look at coccyx. So the coccyx is a great place to look at, kind of again from the bottom up. So we ask the patient, is it okay to push on your tailbone? So oftentimes we'll just do a real brief examination on the outside of clothing. Patients don't get excited by that. We'll look at, see what the position is. Is it rotated, side bent, or flexed? It's easy to do outside clothing. If you start feeling, something's a little interesting, you want to go underneath to feel on skin. Patients are a little peculiar with that. We just let them know what's going on. So if there is a suspected rotation, position doesn't mean as much as function. So what we want to do is find that positional fault and then just do a little spring test. Okay, Rebecca, any discomfort there? So you have to look, is it rotated but springs beautifully, or is it rotated and hard? That'll tell you a lot more. Same thing with side bending. You put your thumb there and just do a little spring test. Does it move beautifully or does it not? With flexion, you're just testing for actual position. In treatment, we'll get into a little bit more. If it's flexed, there's treatments to do rotated side bend. There's treatments for that, but we'll save that for another time. Up from that is your sacrum. Relatively controversial area. A lot of therapists think it doesn't really do much. Some people think it's the driver for all dysfunction. There's the Mark Laslett has the Laslett cluster that shows if you're putting pressure on your sacrum in a couple different modes and it produces their familiar pain, it's pretty much from the sacroiliac joint. So it's some good validity out there through the Laslett cluster. I'm not going to spend time with that on this one. They'll be available in other videos. But what we want to do is palpate for the sacrum, and oftentimes if you're on directly on the underpants or on the skin, it would be best. But for sake of the video, I'm going to palpate the lower pole, mid pole, and upper pole for hardness and pain provocation. That's really an important thing. Upper, mid, and lower pole. Another thing we'll do is palpate next to the coccyx for level. So is the sacrum level? Is it down on one side or up on one side? We palpate what's going on at that level. Before I move on, let's go back to the hip, keep doing the lower, from lower to upper. Have you look at lifting this whole leg, keeping your knee straight, lift the whole leg off the ground. So we're looking to see, does she have an efficient multifidus? Does she have an efficient glute hamstring activation? Rebecca definitely does. Could you go ahead and show us less efficient? So less efficient, you're going to see glute maybe, hamstring definitely, multifidus absolutely not, and then you're going to see the opposite spinal erectors just going nuts trying to lift up the back. I called it a boat drop test, like you're going to put your foot on a boat and just drop it down. So in an efficient state, you palpate the multifidus, raise up that leg, and up it goes in an efficient mode. So we could look at both sides and compare. If you want to, we'll lift up again. You could do a strength test and see if she's really efficient and strong, which she is, which is great. So from coccyx to sacrum, we're going to look at lumbar spine. So from lumbar spine, you'll feel this little drop off. The sacrum will give you this little bit of a drop off. You want to palpate that first, and then you go on to do a central or a unilateral PA, very Maitland style. So if you're doing a central PA, just drop your hand on straight away and just do straight down. Ask the patient, any trouble with that? And then you go up to the next level, any trouble there? So this one is not very comfortable if you have a really hard hand position. So a nice soft hand position on the fleshy part of your hand going up through the lumbar spine. So if you don't find anything there, you go to a unilateral posterior to anterior. I'm doing this on top of the clothes for camera. Normally I would not, but you're going to palpate, bring the fingers together and just push straight down and medially, slightly medial directed, posterior to anterior. Any trouble there? So you could go from side to side. If you want to be really efficient, you want to walk around to the other side at each level. Just takes a little time, and I'm not going to show that for the video. So we'll just go ahead up on the left side. Any trouble there? Any trouble there? And you want, if you're trying to really rule out a problem, you want to put a fair amount of pressure in here to see what's going on. Next, if that really doesn't provoke anything from the lumbar spine, and you haven't seen much from the other ones, we could do a little bit of pressure with press up. So press up for me. So she'll extend up on her elbows first, and then push it a little bit more. So you're really just taking all the slack out to see if she has an extension dysfunction. So we've looked again at anterior to posterior for flexion dysfunction. We've looked at pelvic patterns for side flexion, rotation, and flexion extension dysfunction. And here on prone, we're looking at coccyx, sacrum, and into the lumbar spine. Now I'm going to back up a little bit. So if nothing's going on, have them push up into full extension. So full press up and really put a lot of overpressure on. If they don't have any pain with that, pain's probably not coming from that lower back. You can move on to other structures. Innominate, we'll get into this more in treatment from the IPA style. The innominate, you could look at all sorts of movements, and we're just going to go through this briefly. You're going to look at, can they internally rotate, which we name innominate as how it rotates with the hip. Does it internally rotate? Does it externally rotate? Is there a hard motion, or does it move easy? So I want to put a lot of pressure on this. You just feel it. Does it drop down, or does it bark at me a little bit? We could look at, does it glide inferiorly as well? So you palpate this motion. Does it glide inferiorly, which Rebecca's does? If she rotates from side to side and it really rams into your fingers, you could be concerned that there's some innominate dysfunction going on, which we're concerned with Rebecca. In sidelining, I'm not going to show you this here, but in treatment we'll show you how to examine it. In sidelining during extension, you could look at, does it extend or does it ram into my fingers? So this is a way of doing this, but not efficient because it's hard on the examiner. But as you palpate the PSIS, does it block up and cause problems there? So that's the exam, the little more specific exam. What we haven't done is palpation of muscle. We did that very briefly. But you could look back at muscle, myofascial palpation for bony contours to see if it's more muscle related than joint related. And we did look a little bit at movement, but this video doesn't show all movement patterns. There's some other subsequent videos we'll provide for looking at movement systems, impairment examination of the lumbar spine to just really diagnose it as more of a movement problem, more of a joint problem, more of a muscle myofascial problem. And then you can kind of really focus in on what we have for a diagnostic examination for lumbar spine.